You can identify every ECG based on this thing. Right? So tachyarrhythmia is there. You just identify narrow or wide. If it's narrow, yes, it is supraventricular. Out of supraventricular, how to identify? You see only 2 points: whether regular rhythm, irregular rhythm, and second thing is PO present or PO absent. Based on that, you can identify. If it's a narrow complex QRS complex, if it's a regular rhythm, PO is present, sinus tachycardia. Narrow QRS, regular rhythm, PO is absent. It's a PSVT that includes AVNRT or AVRT. Again, right? It's again narrow complex, irregular rhythm, PO is present. It's multifocal atrial tachycardia. It's narrow complex, irregular rhythm, PO absent, it is atrial fibrillation. Classic, hallmark. You won't go wrong. Even an emergency situation, patient is even suddenly in front of you, you can see the ECG, you can throw ECG here. You can throw ECG, say PSVT. It's just as simple as that. Right? Understand the concept. If you understand the concept, apply the concept in this flowchart, it's very easy to remember. Even in the sleep, you will say. Right? Okay. So after knowing this, we'll go for the wide QRS. We discussed only about narrow. So we are discussing about the wide QRS. Same way. We saw some 1 minute. Yeah. We saw some tachyarrhythmia. I told them divided into narrow. We already saw before. Then we are saying about wide. So we'll discuss about the wide. Wide indicates your ventricular origin. So again here also you go for your same profunda, whether it is a regular or irregular. Right? Again in the regular you go for same profunda, whether it is PO is present or PO is absent. Same irregular also PO present or PO absent. Right? Now let us come to the things. Here it's a very bit complicated things will come. Right? Okay. Right. This is very important point. This one, if you saw the tachyarrhythmia, it's a wide complex. It's a regular with no POS. It indicates your ventricular tachyarrhythmia. That's all. That's it. You saw the wide complex tachycardia. It's regular rhythm only, but there is no PO. It is ventricular tachycardia. Right? There is no wide tachyarrhythmia. Only one is a ventricular tachycardia only. So remaining things and all. So one thing I will say is, if any patient is having narrow complex tachycardia, but if patient has originally bundle branch block, so what will happen if the patient has bundle branch block? Already patient has a wide QRS complex. If patient has right bundle branch block or left bundle branch block, already patient QRS complex is wide. Along with this wide QRS complex, if from supraventricular tachycardia comes, then even though supraventricular narrow QRS, we place a wide QRS. Clear? Right? So that only remaining things will come. So if it is so wide, regular and PO present, it can be sinus tachycardia with bundle branch block. Right? And it's a wide, irregular, PO absent, it can be AF with bundle branch block. Right? Same, if it's a wide, irregular, PO present, it is maybe your multifocal atrial tachycardia with bundle branch block. That's it. As simple as that. Simple things. Any doubt in this? Again, I will explain. No need to worry. You saw the tachyarrhythmias. You saw the ECG showing some tachyarrhythmias. The first thing you have to go in your mind is whether it's a narrow complex or a wide complex. So while you're doing this thing, you have to differentiate whether it's supraventricular origin or a ventricular origin. Right? In the narrow complex, you are seeing regularity and P wave. If PO regular rhythm is there and PO is present, it's a sinus tachycardia. That's it. If regular rhythm is there, PO is absent, it can be PSVT, either AVNRT or AVRT. Right? Right. Similarly, if irregular is there, PO present, it's a multifocal atrial tachycardia. Irregular, PO absent, it is atrial fibrillation. Right? In any of these things, if there is already patient has bundle branch block, then they present as wide complex only. So that's what we mentioned here. Right? If it's a wide complex, same things we can put with bundle branch block, extra you can put. Right? Only thing which is hallmark is this thing, wide complex tachycardia, which is regular with no POS, it is ventricular tachycardia. Right? That's it. Clear this flowchart? Any doubts in this flowchart? It's very easy to deal this flowchart if you know this thing. Just after this class also, just put this flowchart, just apply your mind why it is this thing. It's very easy also. Right? Right. So before going to this thing, okay. Yeah, okay. So just to give a brief summary of this thing, 1 minute you have to remember. Okay. Right. Right. So simple, the basic common ECG is what you are saying. I'm just discussing that thing. Just a basic summary of this thing. Right. So I saw the ECG. Right. First of all, it's a narrow complex, regular rhythm. PO is absent. It's mainly your PSVT. Right. Similarly, it's a narrow complex, irregular rhythm. PO is absent. It is your AF. Simple. Right. Similarly here, it's a wide complex, regular rhythm. PO is absent. It is VT. Simple. Until proven otherwise. Right. And similarly here, it's a wide complex, irregular, PO absent. It's mainly AF with bundle branch block. That's it. And this PSVT includes, as I mentioned, it includes your includes AVNRT and AVRT. Clear? So these are the common ECGs they'll put in your OSCE also, they'll put in your practical also, and common patients come to casualty also. I think it's easy with these flowcharts and easy to remember also, right? Right.
Sir,
Yeah.
if a bundle branch block patient gets PSVT.
Yeah. Very excellent question. So one more thing we missed here is, I don't want to confuse, that's why I missed here. The only thing is wide complex, regular, PO absent, VT, and one more example is your SVT with that bundle branch block. That's called SVT with aberrance. The both are there. I just don't want to confuse the people, so I just didn't mention. Yes. How to differentiate is a magic. We'll discuss about this thing in the last part of the class. Here. Right. Okay. Okay. So let us see some basic ECGs. I'm just putting here some basic ECGs.
Sir,
Yeah.
sir, PSVT and SVT are just interchangeable.
Yeah, PSVT, if just comes paroxysmal, it is PSVT. If it's present for more time, it is supraventricular tachycardia. It includes anything, AVNRT, AVRT, all these things we'll discuss right now.
Okay, sir.
Right. So one important point I want to discuss to you people here. So why this here to discuss. So one thing is this supraventricular tachycardias. It can come from atria or it can come from this appendage or it can come from AV node we discussed. If it comes from AV node, why there is a PVO absent? So this is your atria and this is your ventricle, right? This is your AV node. So what is going to happen here is, now instead of SA node, usually SA node is a pacemaker. So instead of SA node, your AV node is becoming a pacemaker. So it is generating impulses and it is simultaneously depolarizing the atria and ventricle at the same time. So because it is depolarizing atria and ventricle at the same time, atria is depolarizing, ventricle is depolarizing. So normally in normal heart, atria will depolarize, then there is a gap of PR interval, then ventricle depolarize, so QRS complex come in ECG. But in this scenario where AV node is generating impulses, atria and ventricle contracting simultaneously. So in ECG, you cannot detect P wave, but atria's content P wave is present, it is submerged in the QRS complex. That's why you cannot see the P wave. Right? So as you see in the case of your AV nodal re-entry tachycardia or AVRT, all these things, AV node is the pacemaker. So AV node is depolarizing and sending impulses both to atria and ventricle at the same time. So both are contracting same time. So that is why you P wave you cannot see separately. It will be submerged in the QRS complex. That's why we always say PO is absent in the case of PSVT or SVT. That's what we mentioned here. If narrow complex regular PO absent, it is PSVT, AVNRT or AVRT. Right? Right. After knowing this basic, just identify this ECG. What is this ECG? I'll just zoom wait. Okay, able to see this? Right. So identify the ECG past. Go stepwise. The first thing is whether it's tachyarrhythmia or not. It's a tachyarrhythmia, right?
Yes, sir.
Yeah.
Yes.
Then you see regular or irregular. Second thing, narrow complex or wide complex?
It is a
Regular
narrow.
and narrow complex.
Simple.
Right.
It's a
That's
tachyarrhythmia. narrow complex, it's a regular,
No
PVs are present or
PV.
absent? No PVs.
PSVT. No
Your answer
PV.
is
So it is a PSVT.
PSVT. No need to worry anything. In this PSVT, whether it's AVNRT or AVRT, we'll discuss further. It's much more complicated. We'll go one step above next step. Right? Okay. After this again, see this thing.
Regular. Irregular. Oh, tachyarrhythmia irregular without P.
Irregular. With P.
So, with P is P wave is so multifocal atrial tachycardia.
Yes, ma'am.
MAT.
MAT.
Sorry guys, it's raining here. Just a power cut it is. We'll be back in 1 minute only. Just wait for 1 minute. I'll just connect back.
Okay, sir.
Recording in progress.
Yeah. Yeah.
So that was MAT.
Is it okay? Is it clear?
Yes, sir.
Okay.
Little more zoom, sir.
No. Go by step by step. Go step by step.
So
Okay,
narrow
narrow complex.
irregular. Narrow irregular
Okay,
with
someone
P wave.
messaging. Yeah. It's a narrow complex, right? You can identify it's irregular, right? You can identify the thing. Here it's only, see, irregular rhythm is like that. Between two always only just one or two small boxes, one or two large boxes are there, right? But between here, two always there's some more boxes are there. So that indicates your irregular rhythm, right? So narrow complex, irregular. Where is the P waves? Can you identify the P waves?
Some places it is.
So V6. V6, this is QRS complex, then T, then QRS complex, then T, there is no P wave, QRS complex, T, QRS complex, T. Right?
Okay. So it is AF.
It is AF. Messaging 18, someone got disconnected. Okay.
लीड 2 में पीवीओ नहीं दिख रही है सर.
Yeah, sometimes some P wave there, but not for little tachycardia. So here if we see properly, I can show you some also, one or two. But multifocal atrial tachycardia, to say it is a multifocal atrial tachycardia, multifocal, you should have 3 different morphologies of P waves. I am about to go through the definition, right? To say it has multifocal, 3 different morphologies of P waves you have to see in ECG, then only you can say it is a multifocal atrial tachycardia, right? So this usually will go for the AF. It's a narrow complex, it's irregular, there are no P waves, you can label it as atrial fibrillation. Clear?
सर इसमें कोई स्पेसिफिक है कि कौन से
क्या
लीड
बोल-
में देखना है, क्योंकि इसमें लीड 2 में तो थोड़ा पीवीओ दिख रहा था।
लीड 2 में कहाँ दिख रहा था?
सर
See,
लॉन्ग
this is
लीड में
QRS complex, this is
लग रहा है P.
Yeah, I
Sir,
understood.
1, 2,
Wait,
3,
this
4,
is QRS
fifth
complex.
complex. Fifth
QRS.
complex में
Yeah, I'm saying 1 or 2 complex you will see, that doesn't matter, no need to
Okay.
worry. You can see the whole ECG. Okay, in atrial fibrillation also sometimes some PVO can capture. Okay,
Okay, okay, sir.
so for our
Okay,
level,
sir.
just you see the irregular complex, it's narrow complex, irregular, PVOs are mostly it's the AF. So that's why intentionally kept this ECG, because normally exam putting ECGs are, they won't put any PVOs, but patients don't give you that time. Patients present like this only, 1 or 2 PVOs you may see, but don't confuse and don't think like PVOs is there, it's not AF, it is AF, right? Don't jump to multifocal atrial tachycardia unless you have COPD or bronchial asthma or 3 different morphologies of PVOs, then only you can label it as multifocal atrial tachycardia, right? Okay, someone else is messaging, we'll see. Okay, so screen is visible to everyone?
Yes, sir.
Yeah, fully visible?
Yes,
Some
sir.
people are messaging that screen is visible. Any problem for anyone, you can message, you can tell. If anyone who don't have any screen problem or something, please do rejoin. It's just a power cut happened, so that's why some issue happened here, right? Next, identify the ECG. Go stepwise, don't hurry, don't jump. Just manner. First thing, narrow complex or wide complex?
Narrow
Sir, did you
complex.
put a new ECG?
Yeah, and I put the ECG. Able to see or not?
No, it's the screen is in the old
Now?
only.
Still,
This
even
is
now.
previous ECG. Yeah.
Sir, this is previous only, right, sir?
Yeah. Is it now visible now? It's not complete. No. Meeting is on.
Yes, sir.
Visible, sir.
Visible. So this is wide complex. This is wide
Okay.
complex. There is
Wide
no
complex,
P wave.
regular.
Looks regular.
Regular.
Wide complex, regular. Regular, no P wave. Ventricular tachycardia.
VT. Ventricular
Yeah.
VT.
tachycardia.
Simple again, as we discussed, it's a wide complex. First thing it's ruled out. Most of the time, wide complex, if they give you it's mostly VT. Remaining things will differentiate in the coming sections. And second thing is regular. Only just one or two large boxes between two R waves, and there is no P waves. Simple thing. It's a VT.
Yes.
Right?
Yes, sir.
Right, that's it. So these are three ECGs they'll give you. Just the dictum is this only these two things. So narrow,
Yes, sir.
regular, no P wave, PSVT. Narrow, irregular, no P wave, AF. Wide, regular, P wave absent, VT. Or you can say SVT with bundle branch block. Right?
Yes, sir.
Or
Yes, sir.
wide, irregular, no P waves, it's AF with bundle branch block. Simple. So now you can identify your AF, you can identify PSVT, you can identify VT, you can identify your bundle branch block also. Now let us discuss about your PSVT. So PSVT includes two things. One is AVNRT and AVRT. So what is this AVNRT? We'll discuss it now. Right? Everyone can see this slide.
Yes,
Right?
sir.
You can see.
Yes, sir.
Yeah.
Yes, sir.
So this AVNRT we can label it as AV nodal re-entry tachycardia. AV nodal re-entry tachycardia. Simple. So what is the point I said? Here AV node is a pacemaker. This AV node is contracting and it is sending impulses to the atria and ventricle. So because of that, atria and ventricle are contracting simultaneously. So you cannot see the P wave in the ECG. This P wave is getting submerged in the QRS complex. So that's why you are seeing a narrow complex which is a regular with no P waves. Right? That includes what is called as AV nodal re-entry tachycardia. This phenomenon should require re-entry. Okay, re-entry is the main mechanism. So what is this re-entry? We'll just discuss. Okay. So the first thing to happen this AVNRT is these are two prerequisites, very very important. So what are the things? Two requirements are needed. So to have re-entry means, what is re-entry here? Once impulse is coming, it comes from the AV node, go to the ventricle and all. Apart from this, from the AV node again it go re-entry and go to the atria. That is called as re-entry. So for having this re-entry, you need to have two prerequisites. One is what is called as two pathways of different electrical properties. We'll discuss what is this thing. And another is premature complex. So let us see this image. So this is what is called as your atria. Right? This is your ventricle. This is your AV node. This is your AV node. Right? So normally AV node contains two pathways. One is called as fast pathway, other is called as slow pathway. Clear? So please listen to this thing just in 5 minutes. If you understand this thing, it's again very easy. Right? So atria and ventricle, there's a AV node is there. AV node contains two pathways. One is fast pathway, other is your slow pathway. So what is fast pathway? Fast pathway indicates it's fast depolarizing. It depolarizes very fast, and it is slow repolarizing. That's called fast pathway. So there is a pathway is there. In that pathway, depolarization happens very fast, right? But repolarization will be very slow. Slow pathway here, slow depolarization, but rapid repolarization. So electrically, two different pathways are there. That is what is called as two different electrical properties. In the AV node only, there is one pathway and there is second pathway. One pathway has fast depolarizing, other pathway has slow depolarizing. That is what is called as two pathways of different electrical properties. So now what will happen? Let us see. So normally for me and you, for both of us also same thing will happen, right? So the thing is, from the atrium impulse is coming, it go to the AV node, right? The impulse can go to the fast pathway or go to the slow pathway also, right? It's going to the fast pathway because it depolarizes very fast. It will go very fast. It will go to the ventricle also, right? It's same way it goes to slow pathway also, but slowly it's depolarizing, right? So same way it's slowly depolarizing here, It is fastly depolarized through here, and again reaching, it again goes behind. But by the time it reaches here it is slowly coming, and it is slowly depolarized but fast repolarizing. So this part will be already repolarized. So again the impulse cannot travel like this. So the re-entry cannot happen. Understand this concept? Right? Again I will draw just here like this. So for example, an impulse coming from the atria, it will go fastly to the fast pathway, and same way the impulse can also travel like this to the slow pathway. But the slow pathway is again slow depolarizing but fast repolarizing. It will be in a repolarization state. So impulse cannot travel and cannot create a re-entry circuit. So only just impulse has to go like this. That is a normal phenomenon. Right? In this phenomenon, if there is in this phenomenon, right, let me erase this thing. Right. So in this phenomenon, if suddenly premature complex has come, so what will happen? Let's see. So normally normal complex has come, it went to the fast pathway, it go to the ventricle. It cannot go here because it's already in the repolarization phase. So it ends here. So there is no re-entry happens. So always complex will come, they go to the fast pathway, they depolarize the ventricle. It cannot go because it's in the repolarization phase. Right? But immediately what will happen, sometimes there is a premature complex can come. So what will happen here from the atria, it will go into the fast pathway, it depolarizes the ventricles. Now the fast pathway it cannot enter here because it's repolarization state. Now some suddenly premature atrial complex has come. When this premature atrial complex has come, what will happen? This complex, now it cannot travel here because it is already repolarized. Fast depolarized and slow repolarizing. It's already repolarized. It cannot travel like this. Now this impulse will go through this pathway. Okay, it slowly goes to the pathway. By the time it comes here, it will complete its repolarization. So it will create a re-entry circuit. Right? Clear? A bit confusing. Say two different pathways are there. One is fast pathway, one is slow pathway. Normally when impulse is coming, impulse travel through the fast pathway and go and depolarize the ventricle. The impulse cannot travel through the slow pathway because it's already repolarizing phase. Okay, but in this time when some new premature atrial complex has come, it will enter the slow pathway. It comes here. Again it joins the fast pathway and forms a re-entry circuit. Right? Now it generates ectopic focus and it gives impulses from the atria and ventricle simultaneously. So clear?
Okay, sir.
Yeah.
Yes,
So that's why we mentioned here there are two pathways should be present of two different electrical properties. One is fast pathway, other is slow pathway, and definitely premature atrial complex should be there. If there is no premature complex, nothing will happen. So these two should be there to enable to happen. Right? So that's why atrial ventricle.
This fast pathway and slow pathway is normally present in the AV node.
Normal present in individuals.
Okay.
So this one more thing is that that's why because simultaneously the atrial ventricle both will contract. So that's why you cannot see the P wave. Usually P wave is submerged in the QRS complex. But P wave is there. If you identify properly, P wave is submerged in the QRS complex. Right? So now in these two types are there. One is called as slow fast type, other is called as fast slow type. What is this? We will discuss. So slow fast type is okay. Based on how impulse is going from the atria to ventricle. If impulse is going from atria to ventricle using the slow pathway, that is called as slow fast pathway. Here from the atria to ventricle use the slow pathway. From the ventricle to atria to use fast pathway. This is slow pathway, that is fast pathway. That is called as slow fast type. Right? And the reverse is fast slow type. For example, okay. If impulse reaches from atria to ventricle using the fast pathway and from ventricle to atria using slow pathway, that is called as fast slow pathway. Right? Am I clear? Right? Let me repeat again. So AV nodal re-entry tachycardia, for re-entry to happen, for re-entry phenomenon to happen, you need to have two circuits of two different electrical properties. One is a fast pathway, other is slow pathway. So normally in individuals, whenever impulse comes, impulse go to the fast pathway and excites the ventricle. It cannot go to the slow pathway because it's in repolarization state. But in this state, if some premature complex has come, this premature complex will reach the slow pathway and it enters into the fast pathway and creates re-entry circuit and simultaneously excites atria and ventricle. So therefore, there cannot be a P wave. It is submerged in the QRS complex. Right? Now, based on how the impulse reaches from the atria to ventricle based on which pathway, whether slow pathway or fast pathway. We have slow fast and fast slow type of AV NRT. Clear? If impulse reaches it's fast slow AV NRT. Clear? Right. Is it visible clearly? Everyone, is it visible clearly? Any issues?
Clearly visible, sir.
Yeah, right. So let us see now slow fast AV NRT. What is going to happen? We'll see. In the slow fast AV NRT, this is your atria. This is your atria. So this is your ventricle. Okay. So what is going to happen here? From the atria to ventricle, slowly it will come. Slowly it will come. Using a slow pathway, it is coming. Okay. But here in the AV node, from the ventricle to atria, it is taking a fast pathway. Okay. So now what is going to happen from the atria? It's coming actually here in slow pathway it came. Then it starts ventricle depolarization. Ventricle is depolarized. QRS complex has come. But before QRS complex is coming like this, fast it will go to the atria also. Atria also contract. So atria contracts immediately along with the ventricle. Why? Because it's taking the fast pathway. So because it's taking fast pathway, your atria simultaneously contract in the ventricle. So definitely POS are submerged in the QRS complex or just APS just after the QRS complex. So that's what I mentioned here. So slow AV nodal pathway for the anterograde conduction, this is anterograde, and fast AV nodal pathway for retrograde conduction. So atria and ventricle contract simultaneously because retrograde pathway is fast, right? So POS are hidden in the QRS complex or appear just after the QRS, So that is called as RP interval. So R is QRS complex starting point and P is that P wave submerged in the QRS. Maybe sometimes you can see just after the QRS. That is called as RP interval. That RP interval is very short. That is called as diagnostic thing. Right? I will show you in the ECG also. So let us see, for example, this one is a normal phenomenon. It's just as a P wave. It's a QRS complex. This is a T wave. P wave, QRS complex, T wave. Right? So suddenly premature complex has come. So what will happen here is, so this is some QRS complex. Immediately after QRS complex, a small P wave comes. This is small P wave, right? So that small P wave, just immediately after QRS, at the end of QRS complex, you will see some small positive deflection. That is what's called this one. Okay, small P wave. Okay, the small P wave. They rounded here. Okay, so this is called as R, and this is called as P, and this is called as RP interval. RP interval. That is very short. That is diagnostic, right? So you saw the PSVT, like narrow complex tachycardia, regular. Normally PVS are absent. You identify as a PSVT, then you have to identify whether AV NRT or not. Just see for the PVS keenfully, very keen, carefully observe PVS. Just after the QRS complex, if you identify a small deflection, identifying as a P wave, that is RP interval is very short, then you can label it as slow fast AV NRT. Clear? Right, I will show you the ECG, you can understand here. See, for example, this is the ECG here. Right. Some more I will zoom. Right. So normally when you see the ECG, just it's a narrow complex, regular, no POS are there, you identify it as PSVT. Clear? Now you have to identify the AV NRT or not. You are just seeing this thing. Here if you see the V2, okay, V2 or V1 if you see here, see this one. This is your QRS. And small deflection is there at the end of the QRS complex. And similarly in V2 also, small deflection at the end of the QRS complex, every QRS complex. Okay? That is what is called as your P wave getting submerged in the QRS complex or just after the QRS complex. Your RP interval is very, very short. That is called as slow fast type of AV NRT. Right?
Sir, any particular importance of a lead is there? Like we have to
lead
see
usually
only
you
in
will see V1, V2 you will see, because PVS usually see in V1, V2 and also lead 2 also.
Okay, sir.
But in lead 2 you have to see the negative deflection, right? This is negative deflection. Why negative deflection? Because from the AV node, it is going to the atria, it is going above. That is, your positive current is going away from the skin lead. So that's why you see negative deflection here. See at the end of QRS complex, at the end of QRS, this is a small negative deflection, is a small negative deflection, right? So you can identify it by
Can you
small
round it?
What?
Can you round it in the ECG?
Yeah, this one. You cannot see this. Okay, I'll just, when you zoom it, you cannot round it. You can see this one?
Sir.
Yeah, this small. Yeah, so we can say it as, after identifying the PSVT, just go and see your lead 2 and lead V1, V2. In V1, V2, small P wave is there, small positive deflection is there at the end of QRS. Or in the lead 2 and 3, if it's a small negative deflection at the end of QRS, this one again, end of QRS, you can label it as slow fast type of AV NRT. Clear? Right? Okay. Right? I think it's
Yes,
clear.
sir.
Yeah.
Somewhat clear.
Now we'll
sir.
go to the next type. Somewhat clear. We should see more messages. You will understand. I will let you know.
Yes, sir.
Okay.
Yes, sir.
Right. And next thing is a fast slow AV NRT. So what is happening here? We'll see here. Again here it's a atria. Again here it's a ventricle. Okay. From the atria impulse is coming in the AV node. Right. So to the ventricle it's going fastly. Okay. To the atria it is going slowly. Right. So what will happen? Because impulse is going to ventricle, it will produce QRS complex immediately. Right. Now what is happening here? This from the ventricle, that from AV node towards atria, it is going slowly. It is going slowly. So atria will depolarize after the ventricle depolarization. So definitely after some time you will have a P wave. Then you will have a T wave. Right? Because atria is taking time, it's going in a slow pathway. So atria depolarizes after the ventricle. So after QRS complex, you will have a P wave, then the T wave. So that is called as, this is R, this is P, and this is T. RPT. It is diagnostic of fast slow AV NRT. Right? I will show you the ECG also. So I mentioned here fast AV nodal pathway for anterograde, right? And slow AV nodal pathway for retrograde. So atria depolarize after the ventricle because retrograde is slow, right? So PO appears after the QRS having RPT in ECG with RP interval is more. Clear? I
Yes,
just show
sir.
you ECG here. So see the ECG here. Right. If you see the ECG here, it's normal again. Normal narrow QRS complex, regular, no POS absent if you see properly. Okay, you can label it as PSVT. In the PSVT, you have to identify it's a slow fast AV NRT or fast slow AV NRT. If you see again lead V2, you see here, this is your QRS complex, this is your P wave, this is your T wave.
Then the T wave.
And
Yes, sir.
RPT. Every lead also. This is your QRS complex, then comes the P wave, then comes the T wave. Right? That is fast to slow AV NRT. Very important. Clear? So what is happening before the slow fast? Retrograde pathway is very fast. So very fast. So atria also contract almost to the ventricle. So therefore you cannot see P wave or P wave is submerged or just after the QRS complex. But here atria is depolarizing after the ventricle. So after QRS you are seeing a P wave. RPT you can see. Clear?
Yes, sir.
Yeah. Same you can see in the lead 2 or lead 3 anywhere also. Right? This is your QRS complex. This is small s and again this T. Right? The small deflection will be seen between the QRS and the T wave. Right? This is a small deflection again here. Small deflection will see between the QRS and the T wave. Clear? Right? Right. So no need to worry. Yeah.
Lead to that P wave concept you told, no, sir, that it is going away.
Yeah.
That one once again, can you tell, sir?
Nothing, you're placing the leads on the skin. Okay. Depolarization is always a positive current. If positive current is coming towards you, okay, that is, you will get positive deflection. If positive current is going away from you, you will get negative deflection. So 2, 3 AVFR, you are seeing heart from below. So from the below, you are seeing it is going up. Depolarization is going away from the leads. So you will get negative deflection.
Okay, sir.
Right? Right. Okay.
Yes, sir.
Then So just let me summarize this thing. So you get no need to worry anything, no need to remember anything. So just these points remember. So for this PSVT to happen, you need to have a re-entry mechanism, right? For this re-entry mechanism, you need to have a two pathways of different electrical properties, and you need to have a premature atrial complex. Both should be there. It's not plus or minus. It's both should be there, right? Then in the PSVT we have first thing is AV nodal re-entry tachycardia. That means within the AV node only there is re-entry phenomenon is happening, right? And this re-entry phenomenon happening, it is becoming ectopic and it's generating impulses and sending impulses to atria and ventricle. So both are depolarizing simultaneously. So in this we have two things. One is slow fast, other is fast slow. Okay. So slow fast here retrogradely. Atria is also depolarizing immediately after QRS. So therefore you will get QRS and small PV immediately after QRS, or maybe you cannot see also. But in the case of fast slow, QRS, then some P wave, then some D wave. This is the phenomenon, right? That's it, simple. You identified the PSVT narrow complex. It's a regular, no P waves are there. You identified PSVT, very good. Now you have to see P wave, identify the P waves in B1, B2, lead 2, lead 3 and all. You see the P waves, okay? If small deflection is there, QRS complex, small deflection, then D wave, it is fast slow. QRS complex, immediately small deflection is there, you can say it's a slow fast. Simple thing, right? And this slow fast is the most common, almost 90%. This will only will see in the case of your water exams. This is very rare, only just 10% you can see, so no issues, right? Clear? Okay, can I go ahead?
Yes, sir.
Then comes one more master, a bit confusing, but it's okay, we will deal very easily. This is called as AVRT. What is AVRT? It is atrioventricular re-entry tachycardia. This is atrioventricular re-entry tachycardia. Here also between atrial and ventricle re-entry phenomenon is happening, but is not happening through the AV node. That is called as atrioventricular re-entry tachycardia. Then if there is no AV node, then what is happening? There is an accessory pathway. There is accessory pathway. That is very important. There is accessory pathway. So let us draw here. There is accessory pathway. For example, this is your okay, right? So this is your AV node, right? So this is your atria. Okay, ventricle AV node is there here. But what happens suddenly here? Okay, here the patient will have some accessory connection between the atria and ventricle. This accessory connection. Okay, so listen to this again 2 minutes. If you listen to this, if you understand, there is nothing to memorize also. Okay, this is accessory pathway. So what is accessory pathway? Other than the pathway connection atria and ventricle AV node, there is one more pathway that is called an accessory pathway. So one important point I discussed already previously before is, what is this thing? This AV node is a calcium channel. So it's a slow depolarizing. That's why you are having a PR interval in each. Is everything is sodium channel. So it's a fast depolarizing. Simple, again same concept is repeated. Slow depolarizing pathway, fast depolarizing. Two pathways of different electrical impulses are there. Right? So this is the patient condition in case of Wolff-Parkinson-White syndrome. Some patients will have accessory pathway, and that accessory pathway is a sodium channel, and there is a fast depolarizing. Already AV node is one more pathway, so there is a calcium channel, that is slow depolarizing. Clear?
Yes, sir.
Yeah. So let us go to this image. So just see this image properly. Right? Okay. Right. So this is your atria here. This is your atria. This is your ventricle. Okay. This is AV node. AV is AV node. Right? 1 minute. Okay. This AV node. Okay. And this AV is called as accessory pathway. So two pathways are there. Okay. So normally this patient is a Wolff-Parkinson-White syndrome because it's an accessory connection between the atrial and ventricle apart from the AV node. So normal in normal circumstances, what will happen to this person? We will see. So here it's a sinus rhythm. From SA node, sinus rhythm has come. Okay. Sinus rhythm has to go through the ventricle through any of these pathways, AV node or action exit pathway, both are open. Through any pathway, depolarization current can go to the ventricle. Right? But as we discussed, AV node is a very slowly going. It is slowly going because it's a calcium channel. But exit pathway is very fastly going. It's a sodium channel. So it will go very fast. So because it's going very fast, when compared to normal individuals like me, first atria will contract, then impulse will go to the AV node, which is seen as PR interval, then ventricle will contract, seen as QRS complex. But here the scenario is atria contract, immediately it going to ventricle because it has an axillary pathway which is sodium channel. So your PR interval will be shortened, accepted or not?
Yes, sir.
Right? If impulse
sir,
goes
yes,
to AV node, you will see the PR interval. If impulse goes to the axillary pathway, it will go fastly, so your PR interval will be shortened. So that is what the first finding, PR interval will be shortened. Okay, we will show you the ECG also. Okay, now as I discussed, this axillary pathway is sodium channel. It goes to the ventricle. Anything which travels apart from the conduction system, it's not a specialized myocardial tissue. It travels slowly. It travels with ventricular muscle. It depolarizes slowly. So slow depolarization will happen. Slow depolarization will happen. You can see this slurring. Okay, but by the time it's slowly depolarizing, impulse will go from AV node to bundle of and Purkinje curves, ventral contract. So normally, again, ventral contraction will happen normal regular only. Initial part of depolarization will be slow. After later part again, contracts normally only. So clear?
Yes, sir.
Yeah. So this constitutes a triad of WPW syndrome. So I can write in WPW syndrome. There is a triad in ECG findings. So what is this triad? I will write you here. The first thing is short PR interval, accepted or not? Because impulse is going through the axillary pathway, it is not going through the AV node. So axillary pathway, short PR interval is there, right? And then impulse initially goes to the ventricular muscle. So initial part of depolarization is prolonged. That initial slurring is called as delta wave. That is what is called as delta wave. Okay, and then it's incompletely wide QRS. It's not a complete wide QRS, it's incompletely wide QRS. So these three constitute a triad of WPW syndrome. Right? This is just a diagrammatic representation. If you see here, I will just show you here. 1 minute. Right. So this is just a diagrammatic representation only. If you see here, this is short PR interval. This slurring of wave is called as delta wave, and just incompletely wide QRS, that is called as triad of WPW syndrome. This is normal when in a patient is having an axillary pathway, is WPW syndrome. If you take ECG in this normal condition, he will be like this only. That PR interval is shortened, that slurring of the QRS complex delta wave is there, and then comes your incompletely wide QRS complex. That's called WPW syndrome. I will show you the ECG also, you will understand that. One minute. Right. We just focus this thing. Able to see the ECG here?
Yes, sir.
See the lead to here. You see the calculate the PR interval. How many boxes it is? Just calculate PR interval from the beginning of the P wave to beginning of the QRS. How many boxes?
Four or five it is.
4 or 5. Where are the 4 or 5? See properly.
The one.
2 boxes.
It's just 2 to 3. Yeah, 2 boxes.
Three.
So normally 3 to 5 boxes is the normal PR interval. Okay. But here only 2 small boxes are there. It's a short PR interval. Right? Then you see the QRS initial part. There's a slight slurring is there. You can appreciate the thing. Slight slurring.
Yes, sir.
That is called as delta wave. Right? And there's a incompletely wide QRS because initial part is because through ventricular muscle and later go through the AV node. It's an incomplete wide QRS. This constitutes the WPW syndrome. Clear?
Yes, sir.
Yeah. That is what I want to show here. We'll go back to our other slides. Right. So if you any patient of WPW syndrome is there, so normally in normal conditions his ECG will be like this only. So when you take ECG, you identify these findings, you have to know it's WPW syndrome. You have to recognize this thing because these patients can develop dangerous arrhythmias in future with any stress also. So you have to identify them, right? Right. Now the problem has here again, as we discussed, there are 2 pathways. One is your Sodium pathway, the fast pathway, axial pathway. Other is your AV node pathway, slow pathway. We discussed all these things. So same way as in the case of AV and RT, here also two pathways are there. So normally when you take ECG, he is fine. He just has a small PR interval, slight slurring delta wave, and incomplete wide QRS. There is no issue with that. Now the issue when comes when there is any premature complex. When the premature complex comes, that is a very major issue, right? When the premature complex comes, that premature complex can go to the AV node. I will just put one more diagram here. Okay. So this premature complex can go through the AV node. 1 minute. Right. So it can go through the AV node and go through axillary and create a re-entry circuit like this. Okay. Or it can go through the accessory through AV node and can create AV re-entry circuit like this, either clockwise or anti-clockwise. Anything can happen. Okay. So we cannot say. So based on how the premature complex enters this AV node and axillary pathway, we have two conditions. One is called as orthodromic pathway, and other is antidromic pathway. Clear? Orthodromic and antidromic. So what is orthodromic here? What is happening here? Here the re-entry is happening. Okay. Okay. In orthodromic AVRT, you just remember as mnemonic as OAA, auxiliary case, like mnemonic. Just remember this thing. In orthodromic pathway, okay, right? The impulse goes through AV node. Anterograde passes through the AV node, right? Anterograde passes the AV node. From the atria to ventricle goes to the AV node, and from ventricle to atria goes to the axial pathway. That's called orthodromic pathway. Okay. In antidromic pathway, what is going to happen? Here impulse is going through the accessory pathway and exciting the ventricle. Axial pathway and exciting the ventricles. Okay. That is the thing. Clear? So in orthodromic pathway, the impulse is going through the AV node and exciting the ventricles, and again going to atria via axillary pathway. In antidromic pathway, here impulse is going through the accessory pathway and exciting the ventricles, and impulse is going via AV node to the atria. That is the thing.
So can you repeat again orthodromic?
Yeah, one minute again. See, this is your atria, this is your ventricle. Okay. How impulse is going to the ventricle, from the atria to ventricle, which pathway it is choosing, based on that we have orthodromic and antidromic. Okay. In orthodromic, impulse is going from atria to ventricle through the AV node, and exciting the ventricle, and again impulse going from ventricle to atria through the axillary pathway. That's it. One pathway, remember, remaining is reverse of it. Clear? In orthodromic pathway, impulse is going from atria to ventricle through the AV node and exciting the ventricle, and from ventricle to atria to the axillary pathway. Okay.
Okay, sir.
So here in orthodromic, because impulse is going from the atria to ventricle through the AV node is a specialized conductive tissue. You will have a narrow QRS complex. Accepted?
Yes, sir.
Yeah. But in the case of antidromic pathway, here impulse will travel through the axillary pathway and excite the ventricles, and again reach atria via AV node. Because impulse is traveling through the accessory pathway, it is slow, so your QRS complex will wide.
Yes, sir.
That's it I want to mention. So only thing is in orthodromic pathway, okay, impulse travel from atria to ventricle via AV nodal route. So you have narrow complex QRS. Okay. But in the case of antidromic pathway, right, impulse travels via accessory pathway. So that's why you'll have wide QRS. Okay.
Yes, sir.
Right. So one important again clinical point I will say here, very important. Right. Orthodromic, it travels to AV nodal, so it's a narrow complex. It looks exactly similar like a AV and RT only. Similar only, narrow complex, regular. Okay, no PVs are there. Narrow complex only. Okay. Antidromic, because it's going through the axillary pathway, you have wide QRS. It looks exactly like a VTE. Because wide QRS complex, regular, no POS, you will VT. Clear?
Yes, sir.
Sir, can you
that's
please explain the mnemonic OAA?
No, it's just a mnemonic only. I kept orthodromic pathway. Actually, this anterograde pathway is to the AV node. It's just my mnemonic I kept. It's nothing, any concept or anything. In orthodromic, anterograde conduction, that is from atria to ventral conduction, is to AV node. Like that I kept. But okay.
Thank you, sir.
Okay. Right. Clear? So this is what I wrote. AVRT, atrioventricular re-entry tachycardia. AV node is a calcium channel, axillary pathway is sodium channel. So one is fast, other is slow. So you have two different pathways. Normal conditions, what is this WPW syndrome? You will have just a small PR interval, slight slurring delta wave, and incompletely wide QRS complex. That is a normal phenomenon. Any patient, young patient, has come to you, a history of palpitations, suddenly ECG they come to you, delta wave is there, short PR is a WPW syndrome. Admit him and do some. You can do radio frequency ablation of an axillary pathway. Otherwise, you will develop into tachyarrhythmias later. Right? Now, when premature complex comes, well, how this complex enters from the atria to ventricle, it divides the scene. If this complex enters from atria to ventricle through the AV nodal pathway, that is called as orthodromic, it exactly represents like AV NRT. You cannot differentiate these. Slight points that I will mention to you. Right? If the premature complex reaches from atria to ventricle through the accessory pathway, you will have wide QRS. It exactly resembles like a VT. You cannot differentiate. Right. Okay. So clear. Can I go to the next slide? Right. Just see. Let us see this orthodromic AVRT. Just read the lines. Nothing is there. In orthodromic AVRT, anterograde conduction, that is from atria to ventricle, occurs via AV node, resulting in a normal direction of ventricular depolarization. Accepted? Rate is usually 200 to 300 beats per minute. Right? So now what is happening, we'll see. So as I discussed in orthodromic pathway, so impulse is traveling from the atria to ventricle through the AV node. Okay? And now from ventricle to atria, it is traveling through the axillary pathway, which is a fast pathway. Right? So here also you may see the P waves after the QRS complex. Right? So because already through AV node QRS complex is depolarized, but P waves can be seen because it is slow pathway. It's like right, it's what to say? It's a fast pathway only. So it is just immediately after QRS complex, you will see the P wave. That's what they mentioned here. Right? So retrograde P waves are usually visible with a long RP. Okay. Same in the AV NRT also, the slow fast pathway we discussed. Same retrogradely you will see the P waves because immediately after ventricle contract, it will just immediately after the QRS complex. So same way here also P wave can be seen immediately after the QRS complex. Right? So this rhythm can appear similar to AV NRT, but the RP interval can exist to differentiate. In the AV NRT, this P waves appears very early, so we either don't see them or just partially see them. Okay? So simple thing is, in the AV NRT we discussed slow fast and fast slow. As I discussed, fast slow is very rare, only 10%. 90% is slow fast. Okay? You have to differentiate that AV NRT with the AVRT. When you compare this slow fast and this AVRT, their POs are immediately submerged in the QRS complex. Here the POs can be little late than the before. In AVRT, retrograde POs occurs later with a long RP of 70 milliseconds. Any doubts? I think full of doubt, I think. Any doubts? Is it clear or not? No problem, we can repeat, no issues. Where you people lost? We can explain, no problem. Yeah.
Yes, sir.
Sir, it
Whatever.
looks
You don't know.
exactly like AVNRT, and it
Looks
looks the
exactly
other
like
one.
AVNRT. The other
Till
looks
there
exactly
we
like
got it. AVT. Till there I understood.
till there you understood, right? Okay. So what I'm saying is now it looks exactly like AVNRT. So you have to differentiate whether it's AVNRT or AVRT. Okay. Yeah.
Hmm.
So in AVNRT, what we will say is we already discussed in AVNRT, the POS will come immediately after the QRS complex, right?
Yes, sir. They are
Here in
buried.
AVRT, POS comes a little later than the QRS complex. That RP interval is more than 70 milliseconds. That's it. That's it.
Sir, again, this is seen in the V2 lead only.
But yeah, same V2. In V1, V2, you will see
V2.
the positive deflection. In 2, 3 AF, you will see the negative deflection.
Okay, sir.
Right?
So if we
Simple.
want to see this AVRT, AVNRT, we have to concentrate on lead V1 and V2.
Lead V1, V2, 2, 3 AF, you see where there is small deflection, you just see the duration. If it's just exactly
Okay.
submerged in the QRS complex, it's there's very RP interval here less than 70 milliseconds. It is AVNRT. If it is more, it is a AVRT. That's it.
Okay, sir.
You don't need to go and differentiate slow fast and fast slow. You forget about fast slow, no need to remember. You just remember slow fast AVNRT and AVRT. You have to differentiate by using RP interval. If POS are just submerged in the QRS complex, just after QRS complex, it's AVNRT. If it's a slight delay after QRS complex, it is your AVRT.
Yes, sir.
Okay, let us see this ECGs. You will understand this thing. Then normally when you see the ECG, what can you see here? Just simple. Go in a flowchart wise. Narrow complex or wide complex?
Narrow complex.
Narrow complex. Regular.
Regular.
P waves absent. Present.
Regular P waves are absent.
Bas khatam. Narrow complex, regular P waves absent. You diagnose the PSVT is done.
PSVT.
You're already
So in
80% marks are
PSVT,
gone. Yeah, it's a PSVT. Now this PSVT can be AVNRT, AVRT, we don't know. Just go through the rate. First see the rate. This much of rate you will see in the AVRT only. Okay? So it's more than like near to 200 like that. Okay? Okay?
Yes, sir.
Usually AVNRT will be little less rate than this, like 150, 140 like that. There is one thing to differentiate. And second thing, you go and see your V1, V2 and also lead to any deflection. Anything is there, you see. Anything you can appreciate. Anywhere you can see. If you see here in the V1, I don't know whether you can see or not. This is the V1 here.
Small.
Yeah, it's small. Okay, this one. Okay, from the QRS to POV is very, some more duration is there. It's not submerged. Here also you can see here. You can see here. You can see that?
Okay, sir.
Yeah, here also you can see here again. This here also V1. So just to go through go to V1, V2, see any deflection is there or not. You see small deflection is there. It's just near to QRS complex. It's far from the QRS complex. If it's near to QRS complex, AVNRT. If it's far from QRS complex, it's AVRT. Okay.
Yes, sir.
This is AVRT.
This is
AVRT.
This is AVRT. In AVNRT, this PO will be just near to the QRS complex. Just maybe it will be here, just near to the end of QRS complex, or it will be submerged in the QRS complex. In AVRT only, you will have some distance between the QRS and the P wave. Okay?
Yes, sir.
Yeah, that's it. Simple. Okay. Okay, simple. This is your orthodromic, because see, this is AVRT. Which type of AVRT? Orthodromic or antidromic?
AVRT and RP more than 70. You have to see the R and P.
No. Just see, this first AVNRT can happen or AVRT can happen. In AVRT, whether it's orthodromic or antidromic. Antidromic will have wide complex appears like a VT.
Wide complex.
Orthodromic will have
so
narrow
this is
complex
orthodromic.
like AVNRT. Okay, so it is a AVNRT
orthodromic.
Orthodromic AVRT. In orthodromic AVRT, you will see the RP interval a little prolonged. This is simple. Right? Identify this ECG again.
So this is a tachyarrhythmia. Regular.
Wide complex and
PV is
narrow complex.
absent.
Narrow complex.
Narrow
Narrow
complex.
complex. Just count
Narrow
the QRS
complex
complex. Count QRS complex, please.
2 small boxes.
2 small boxes. Okay. Yeah. Now it's a AVNRT or AVRT with orthodromic pathway.
So here the P wave is just at the end of the QRS.
Yeah.
Yeah, so it is
This
AVNRT.
is the PV. So you understood now how to approach and all. That is the thing.
Yes, sir.
Yeah, that's it. Simple. Okay. So if I control the rate of this patient, that's it. This is the important thing. Nothing else. Okay, clear?
Yes, sir.
Right. So I go to the antidromic. I already told antidromic is also rare. No problem. As the name suggests, it involves anterograde conduction via the accessory pathway. Okay. Retrograde conduction is the AV node. So definitely has a ventricular demand. So almost broad complex tachycardia is something like a VT. We already discussed, which can be easily mistaken for VT. Okay. So one more important thing I want to say is, if any ECG, if in a casualty you saw ECG, it's a wide complex tachycardia, which is a regular with no P waves. You have either VT or you have antidromic AVRT. That's it.
AVRT.
Okay, but always treat like a VT. Okay, don't treat like antidromic AVRT, patient will die. So if you get a wide complex regular no P waves, treat like VT. Why? I will discuss in the management issues. Treat like VT. Okay, after treating like VP, VT, then after you correcting the rate, then maybe you saw the ECG. In ECG you can see delta wave, then it's WPW, then you can say, oh, it is not VT, it is AVRT. Then retrogradely in conclusion you can give, but always treat like VT. Why? I will tell you later. Okay. Now see this ECG. Narrow complex or wide complex?
Narrow complex.
Narrow complex or wide complex?
Wide complex, sir.
Wide
Complex is opened up.
Wide complex.
Yeah, complex is
Wide
complex
complex.
opened up. So wide complex, regular, irregular,
Regular.
Regular.
Previous no option. So VT or antidromic AVRT.
Antidromic AVRT.
So treat like a VT. After treating, rate is controlled. Then you saw the ECG. Then ECG is showing this thing.
Yes.
Delta wave is there. So it's developmentally simple. Like that only you have to diagnose. Otherwise you cannot diagnose like, I will apply my mind, I will see antidromic AVRT. We cannot do over actually. Okay, because patient will die. Because VT is, we cannot miss. Patient won't get any time. Okay? Clear?
Yes, sir.
Yeah, I think I am clear. So after this thing, just I want to give a summary of the narrow complex tachyarrhythmias. See, in the casualty you are there, you went to the duty or you go to the exam also, and the exam they're giving you ECGs and all. The first thing you are seeing is tachyarrhythmia is there or not. How you are seeing? Just by calculating the R wave boxes, number of boxes between two R waves, you calculated, it's a tachyarrhythmia is there. Right? The second thing you are seeing is it's a narrow indicates your supraventricular tachyarrhythmias. Right? Then you see it is a regular or irregular. Mostly regular indicates your mostly PSVT, irregular indicates your AF. Okay, AF no issues are there, you can easily identify. Irregularities there, POVs are not there. Narrow, AF happy, very happy, no issues at all. Regular only PSVT is there, you don't know whether it is a AVNRT or you don't know whether it is a AVRT orthodromic pathway. Okay, then we go to the V1, V2, 2 and AVF, the 2-3 AVF, right? You saw small deflection. That small deflection is near to the QRS complex, that is AVNRT. That small deflection is far from the QRS complex, that is AVRT with orthodromic pathway. Clear? Easy?
Yes, sir.
Any complication is there? Very easy, very conceptual. Just if you know the flowchart how to classify them, then you can easily identify.
Yes, sir.
Right? So even in the sleep also, suddenly we are doing activities as AP section process, not suddenly PGs will come, some ECs come, we just say easy like that, this AVR will through like this. So because it's like this only. just see step by step tachyarrhythmia, narrow complex, regular, previous absent, PSVT, AVNRT, AVRT, C is the V1, V2, any deflection is the deflection 3 is far from or near. Period AVNRT, for us AVRT, right?
Yes.
Very simple. Right. So can we go ahead with white complex, or to become late, we can proceed in the other day?
No, sir, we
Go
can go
ahead,
ahead.
sir.
I think it will take so much time. In the VT also we have to discuss many things. DDS VT we have to discuss. Percentage points we will discuss. Yeah, it will take time. Okay, we'll stop the class here. In this week again I will take one more class regarding VT. So after VT again we give a complete summary of the tachyarrhythmias. Any doubts are there until now?
Yes, sir. No, sir. Sir, VT and VFib,
Yeah.
how to differentiate? They asked in Viva today.
VT and VP we cannot see. VP is complete scribbling pattern. It's complete because
Okay,
so much
sir.
of rate is there. That's it. I didn't discuss about
Okay.
atrial fibrillation also. Same scribbling pattern, sawtooth waves are there. That's it. In ventricular
Okay.
fibrillation, just scribbling pattern.
Okay, sir.
So in this, what type of questions they will ask you is actually narrow complex tachycardia. They will ask you. In the narrow complex
Okay,
tachycardia,
sir.
what is PSVT? How is AF? They will ask you. In the PSVT, what is AVNRT? What is AVRT? They will ask you. So how will you differentiate Wolff Parkinson-White syndrome? Very very important. And how will you differentiate AVNRT and orthodromic AVRT? They will ask you. If you say that
Okay.
extra 1 point, it's a very high edge point. I'm saying you. If you tell examiner like AVNRT, orthodromic AVRT, we are differentiating using a RP interval. This is short in case of AVNRT. It is long in case of orthodromic AVRT. Then you're some extreme level you went already. Okay.
Okay, sir. Okay,
After this, we'll discuss VT. In the VT, what we're going to discuss is what is VT, wide complex tachycardia, what are the different types of wide complex tachycardia. So how will you differentiate wide VT from other wide complex tachycardias? What are the characteristic signs? It's very very important question. Without that question, no exam can go also. Definitely every exam, that's a question. Okay, we'll discuss in the next class. So
Okay,
we'll stop
sir.
the class here. I'll let you know when is the
Sir.
next
Yes,
class.
sir.
Yeah, any doubts?
Sir, just show 26 and 27 number slide.
26 and 27, I don't know what are the slides. This one?
No, another. Yes, this one.
This?
27.
Yeah. Okay, if you don't remember anything also,
Okay.
no problem. Just only this prerequisite is important. That is for your VT. 2 pathways are needed and 1 premix atrial complex is needed. That's it. You remember that thing? Enough. Slow fast is more common there. In the AVRT orthochromic, you have to differentiate based on RP interval. That's it. In clinical practice also, you use only same thing, nothing more than that. Okay.
AVRT is different and WPW is different, no, sir?
WPW syndrome is the patient. WPW is the
Patient.
patient. For example, I am the patient. I have accessory pathway. I have WPW syndrome. So normally, if you take
Okay.
ECG for me, I will have that triad of short PR interval, that delta wave, and all this triad is there. If some premature complex comes to me, I will develop
Okay.
into orthodromic AVRT. So
Okay.
as a physician, what you have to do is any young patient has come. This is also asking question I can ask you like young patient has come with history of palpitations, but by the time he approached the casualty, there are no palpitation. Patient is completely fine. You took the ECG. ECG is showing this finding that is delta wave. What is the diagnosis? WPW syndrome. Okay. So what you have to do? You have to admit the patient. You have to go for the electrophysiological study. Wherever the XR pathway is there, you have to do radiofrequency ablation.
Okay.
Otherwise, you will go into orthodromic AVRT. Right?
Okay, sir.
Yeah, that's it. Right, we'll meet in the next class. Sorry for the interruption, very technical. Whenever I start the class, some thunderstorms, some rains and all will come. I don't know why. Okay.
Okay, sir. Thank you, sir.
Okay, thank you. Bye bye. Good night.
Good night, sir.